Morning, everyone. Welcome to our program today. Angela and Carl will be doing the introduction of our speaker. For those of you who may not know, Parkinson's Social Network is a nonprofit charitable organization. It's all volunteer run by individuals who all have a personal connection to Parkinson's disease. We run monthly programs virtually. We welcome everyone, people with PD, people who care for someone with PD, and anyone else who's interested.
Well, thanks, Nancy. Yes, Carl and I are going to do, I'm not going to read all of Dr. McDaniels' bio, but we're so pleased to have him with us today. Dr. Bradley McDaniels is a assistant professor and program coordinator for the Rehabilitation Studies program in the Department of Rehabilitation and Health Sciences at the University of North Texas. And it's been my pleasure to know Brad for at least a few years. It seems like a long time, but it's been pretty short. But we were fascinated with his research, and he has a personal connection to Parkinson's, which makes his compassion for our community even deeper. Carl, do you want to say something else?
It's been great knowing Brad. He's the coolest doctor I know.
You must not know many doctors, Carl.
I know a lot of doctors for 40 years of it.
And I'm going
But I want Brad to tell the story about how we became a doctor. That's my. I think that's pretty cool, Brad. So I think you should tell that story.
Okay. I sure will.
Okay.
All right. Well, thank you for the kind introduction. Let me find my slides here and get them shared. Get these in the right. All right. You have one big slide now that you see?
We do.
Yes.
Yeah.
Perfect. All right. Well, again, thank you for having me. I always love getting to connect, Angela, with you and Carl. You guys do such wonderful work for the PD community, leaders in the field. And I know that your work is greatly appreciated by many, me included. So thank you for the invite. Little bit about me. Angela kind of started off, and Carl brought up another thing that I can certainly talk about for a second. My connection with Parkinson's, my mom was diagnosed almost 14 years ago at this point. And I had spent nearly 20 years in the pharmaceutical industry in sales the whole time. And shortly after my mom was diagnosed, I began thinking, what can I do to help my mom? And at the time I was 42 years old, I think. And I thought, crap, I'm too old to go to medical school. Neurology is a pretty long road at this point. And kind of serendipitously fell into the PhD world and didn't actually realize at that point in my life how much I love school and learning. It wasn't that way when I was an undergrad back in the late 80s. But I was fascinated with research, fascinated with writing, Parkinson's. And so I made the shift in careers and was fortunate enough to spend some time with some great people. I spent a couple of years in the Virginia area. I was at Virginia Commonwealth working in the School of Medicine there for 2 years, just really learning Parkinson's disease. I probably, like most people who are thrust into this world, know nothing, right? I knew Muhammad Ali and Michael J. Fox. That was all I knew about Parkinson's disease. And so I was learning like probably most of you and have become fascinated with it. And fortunately have gotten connected with some outstanding mentors across the country who have taken me under their wing and done some great work together. So that's the interest that I have in PD. And I'm excited to, anytime I can talk about these things. And we'll talk a little bit more about why I talk about the things that I talk about, and kind of go from there. So we're going to talk a little bit today about psychosocial challenges with PD. And as a quick, let me click the right button here. Quick overview. I think I'm probably preaching to the choir. Most everybody on here understands how significant Parkinson's disease is, right? It's the number 2 most common neurodegenerative disorder after Alzheimer's. The stats on Parkinson's are impressive, but the one that gets me, 90,000 new diagnoses every year, right? We are exploding with Parkinson's, and it's just going to get more, right? The graying of America as we age, right? The number one risk factor for Parkinson's disease is age. So we age and we have a higher risk of getting Parkinson's. So it's critical that we as a community continue to push. Our legislators help the researchers begin to find things that can improve lives. And, Parkinson's has always been a movement disorder since it was discovered back in the late 1800s, right? But I think that as we look through the Parkinson's literature, as you all have your experiences and you talk with other people who have had their experiences, I think that the problems with Parkinson's disease are not so concerned with the motor symptoms, right? We have some meds that do a fairly decent job. Most people whom I talk to about Parkinson's talk to me about the non-motor features: fatigue, sleep, chronic pain, GI issues. And the research, I think, is fairly consistent with that it's these things that people will say, those are the things that affect my quality of life. And so I began looking at, what about the psychosocial issues, mental health, things like work, right? Someone gets diagnosed with Parkinson's disease, they're employed, they're providing for their family. All of a sudden, things might change, right? How does that affect quality of life? What about relationships, right? We change. We have role changes in our lives, right? One person had the role of provider, or one person had the role of taking care of everything at home. All of a sudden, these things shift. And now we begin to have some challenges in relationships. So those are the things that I'm really interested in, and largely what I'm going to be talking about today. So again, you all know this, right? Parkinson's disease affects everything about our lives. Again, we typically think of the movement. We think of tremor, gait abnormalities, dyskinesias, things of that nature that are visible, right? But we often overlook the emotional, the psychological, the spiritual, all of these aspects that are also significantly affected by Parkinson's disease. And it's important that we look at things holistically. I think that Dr. Indu Subramanian, whom I do a lot of work with, she and I have had these discussions about, as we're shifting from a medical model of treating to a wellness model of treating, where we begin to look at the whole individual, where we begin to look at not just trying to fix a problem, but actually be more proactive and helping in the prevention piece and showing things that people can engage in that improve quality of life. I think that message is being heard, and I think it's beginning to gain more and more traction, because we have, as we jokingly say, more people who drink the Kool-Aid, who are talking about these things and who say, yes, those are things that we need to begin paying attention to. So we did some work a couple of years ago looking at what are the issues that really affect quality of life for people with Parkinson's. And, didn't mean to hit that. And so we came up with a few things in this study that we looked at. And if you look at the top right-hand corner of this slide, demoralization, apathy, stigma, loneliness. Those were 4 things that we found that were significantly associated with decreased quality of life, right? And so as we talked about these things, we began thinking, well, I think one of the challenges in research is oftentimes we do a really good job of describing problems, but we often fall short of answering the question of, so what? What do I do about that problem? And so as we began thinking about this work, we were saying, what are the things that we can do to improve these 4 things that negatively impact quality of life? We talk about things like self-efficacy. How do we build self-efficacy? Just as a definitional component, it basically means, do I think I can do it? right? Henry Ford said, whether you think you can or whether you think you can't, you're right. And part of the problem with that is if I don't think I can exercise, let's say, odds are pretty good I'm not going to exercise. So what can we do to improve some of these things? Self-efficacy, building resilience, right? The ability to bounce back after something happens in your life. Social support. I'm going to spend a fair amount of time today talking about that. It's critical for outcomes. Then this idea of psychological flexibility. Am I able to shift when something challenging happens in my life, right? I've got this idea of the way that things are supposed to go. My life's going really well. I get thrown a curveball, i.e., Parkinson's disease. Can I shift and adjust to this new challenge that I have? People who can have better outcomes. People who can't have poor outcomes, right? Makes total sense. So this was the framework for what I'm going to talk about today as we begin looking at some of these different things. So we look at stigma. I got to move something on my screen here. Sorry for this. I keep tapping something that I don't mean to tap, and
No
it's not
worries.
working.
No worries, Brad. We actually had a comment in the chat.
Yeah.
David made a comment about how the demoralization is a better classification. So
Yeah. And David, that's a great point. It's funny because we talked about this term. I was, again, doing some work with Greg Pontone and Indu, and Greg was talking about how he said, Brad, I see he's a geriatric psychiatrist. He says, I see these patients in clinic and they're not depressed, but they seem like they're depressed. And he said, there's something different going on. And he knew the term demoralization because of his medical training. And so he and I started talking, and he says, the only literature that exists for demoralization is in the world of cancer research, end of life research. And he said, we need to start talking about this in Parkinson's disease. And I'm going to put a pin in that because I've got some slides coming up where we're going to talk a little bit more in depth. But great foreshadowing question, David.
Right.
So one of the things that we looked at in that paper that I just talked about was the idea of stigma. Stigma is a critical issue really for all people. And stigma is the easiest way to understand stigma is something that a characteristic of an individual that is viewed as discrediting, makes an individual seem less than, unworthy, incapable, right? And those are very subjective things, right? What one person could deem unacceptable, another person may not. But the challenge with stigma is when we begin to internalize stigma and we begin to feel like we're less than, I'm incapable, other people are judging me, they're not accepting me, we oftentimes begin to withdraw from society and not get involved. And it's a big deal with people with Parkinson's. Half of the people with Parkinson's say they try to conceal their disease. Right? And we've all seen it. Maybe some of you have done it, right? You've got a trimmer in your right hand. And when you're sitting down, you hold your hands so that you don't have the trimmer, or you can reduce it to some degree so that there's not the judgment. 50% of people with Parkinson's say they've experienced discrimination because of stigma. Somebody looking down on them because of the way they walk, the way they talk, their facial expressions or lack thereof, their tremor, dyskinesias, whatever it may be. So it's significant. Obviously, the stigma is more associated with the visible signs because others can't see what's going on in our heads, right? Others don't know that we're struggling with depression, which carries its own stigma, right? How often does someone who's struggling with depression not want to go to see a provider because of the stigma of mental health? And I think one of the interesting things is that it's typically higher in the younger population, and it makes sense, right? You get diagnosed with Parkinson's disease at 30, and everyone assumes that you should be in the prime of your life. And if you're walking with an abnormal gait, There are oftentimes other people may think, has this person been drinking? Are they on something they shouldn't be on? Right? The literature talks about those things. And so when you're young and you're working and you've got kids and you're supposed to be, right, healthy, well, and you're not, people begin to ask the question, what did you do to cause this problem? And there's a stigma associated with that. Some of the times when I give a talk like this, I'll show a slide of lung cancer. And I'll say, what do you think of when you see this picture of lung cancer? Oftentimes the response is, someone did something to deserve that, right? For many, many years, there was the association smoking and lung cancer. Still is, right? It's not causative, but the correlation is pretty high. But there are many people who get lung cancer who have never smoked. So that stigma causes the way that we look at someone to be different. And throw in the fact that so many with Parkinson's are diagnosed later in life and are aging. Now there's also stigma associated with age, right? Older people aren't as sharp, right? That's the stigma. They can't communicate well. They don't have any stamina. They can't walk with a normal gait. All of these things. So we tie that in, and now all of a sudden you've got double stigma, which increases the challenges associated with it. So this is an area that there's a lot of talk in the Parkinson's world right now from a research perspective on how can we navigate stigma and the challenges of that. So the question is, Brad, so what? Yeah, I get stigma, but why do we need to talk about it? Well, I mentioned one of the challenges is social withdrawal, isolation, loneliness. If I think people are judging me and I have a noticeable tremor, I may choose to not go to an exercise class because I don't want people there to judge me, right? So now I'm staying home. I may not engage in my social relationships. There may be some incontinence, right? Stigma associated with incontinence, right? Now, all of a sudden, I don't want to engage in social gatherings like I used to because of the fear of something happening, which also creates anxiety, right? Always thinking, am I on or am I off right now? When did I take my meds? When is the off going to happen? What can I do in this time frame while I'm on so that I'm as asymptomatic as I can possibly be? And then there's the reduced help-seeking behaviors. One of the challenges with stigma is when medical providers have stigma toward patients. It happens, right? We would think that, wow, that would never happen. Well, it does. The literature is pretty clear about that too. And if you think that your provider is judging you negatively, how comfortable are you going to that provider for care? I would argue probably not real comfortable. Then there's shame associated with stigma. Thinking, was there something that I did? Am I less of a person? Am I incapable? Right? Those types of things. And then, of course, depression and demoralization. Anytime that we feel like we're being judged negatively, we can end up with some depression and demoralization. So that's the challenge of stigma, right? And so David brought this up, and it was a great lead in to this discussion. But this idea of demoralization, and I alluded to this, that we got it from the cancer literature. People get to the end of life and they begin to feel like they have no hope. It's helpless, meaningless. You have this existential despair. Life, as I know it, is over. And those are really the three signs that we see in someone with demoralization. And really the easy definition is it's really just an inability to cope with a pressing problem, which makes sense. I get diagnosed with Parkinson's disease and I go, holy cow, I have no idea how I'm going to manage this. How am I going to deal with the emotional challenges that are associated with this? I may not have well-established coping strategies that I can use to help me with this. And you begin to give up. There's nothing else I can do. And it's going to be progressive, right? That's one of the challenges with PD. It's not going to get better over time.
Brad,
And so, yes,
I have a question for you.
You bet.
So as soon as somebody's diagnosed, I mean, you're in the neurologist or movement disorder specialist office and you get that diagnosis, and then it's like the flood of the shock of the diagnosis, but then also what do I attack first? Is it the exercise? Is it the telling my family? Is it my job? It's the overwhelming tsunami, I guess, of stuff. I mean, the demoralization could start right at that particular moment.
Absolutely. And I think that's what Greg Pontone was talking about when he sees this, because at the moment of diagnosis, there is this flood of stuff. And I heard that, I've heard this story, and I heard it with my own mom, that at the moment of diagnosis, once you hear you have Parkinson's disease, often that's the last thing you hear in that moment. Your mind begins to go, oh my goodness, what now? Am I going to die? Because maybe you don't know anything about Parkinson's. I can't do everything I used to do. And you begin to think it's hopeless. I can't do it. And I don't know how I'm going to deal with this. How am I going to tell my family? And even a better question, am I going to tell my family? Right? Because oftentimes that doesn't happen because you're trying to protect, trying to hide, trying to not bother someone else with your problem. So yeah, and Angela, it's a great question, because I think that demoralization happens along the trajectory of the disease. I would even argue that demoralization happens in prodromal PD, right before diagnosis, when some things start to change, right? Maybe you're having severe constipation, and you'd have no idea why you're having it. Doctors aren't diagnosing it well. They're giving you psyllium husk and these other things to try to help with that. It could be prodromal PD.
Whoa.
You're having RBD, where you're acting out your dreams and you're not sleeping well and you're having extreme fatigue. I think all of this stuff can lend itself to this feeling of hopelessness, helplessness. This is terrible, and I don't know what to do.
Brett, that happened to me. But I was told at 23 I had a chronic degenerative illness that with no cure. Where's the hope in there in that diagnosis? And actually, I've had good days, much better. I do get better days than others. So I do get better. I've seen we've been better than the last year even sometimes. They have to, maybe the diagnosis needs to be changed in the way we're programmed.
Yeah, and that's a great point, Carl. We wrote a paper on that a year and a half ago, talking about delivering the diagnosis.
Yeah.
About how do we do that with compassion and care. And it's critical. And I get that I've not been there, but I can imagine a chronic degenerative condition can lead to an immediate feeling of hopelessness. No question about it. It's a reactive depression that can happen in that moment. And I think that the challenge becomes, over time, how can we reframe the way that we look at things? And maybe it's hopeless in a sense. Yes, it's not going to ever get better. And it comes to a place of accepting that. But it's, maybe I can't continue to do this part of my life the way I used to. But there are other things that I can engage in. The things that you and Angela are engaged in now, that I don't know your lives years ago, but maybe there was a time that you weren't engaged in the things that you're engaged in now that give you hope and meaning and purpose in your life, that we're going to talk about in a minute. But it's a really tough problem. And Carl, the challenge with demoralization is you can't treat it with a pill. And that's really one of the distinguishing factors. Is with depression, you can do an SSRI or an SNRI 6-8 weeks later, you're probably going to see some improvement in depressive symptoms. You give those pills to someone who is demoralized without depression, you're likely not going to see improvements, because it's not a chemical issue, right? It's more of a behavioral, a thought, a challenge of, I need some skills, i.e. coping strategies, to help me deal with life. And that's why we began this discussion with it. We've got a paper that's under review right now that I think is going to be exciting in the Parkinson's community, that's going to come out and lay all of this out about demoralization and really describe it well. So it's clearly from the responses, it's an interesting topic, and I believe you all have experienced this. Let's be real. I think everybody in life experiences demoralization from time to time. Doesn't have to be Parkinson's disease. Struggle in life. And we learn to adapt over time. And Parkinson's disease is just one of those significant things that we face. And the demoralization hits almost immediately when that diagnosis is made.
Did anybody else have a comment or question here, since we have a little pause? All right. Well, I guess that's it, Brad. I just thought I'd
All right.
throw it out there.
Yeah, please. Love it.
Thanks, Brad.
You bet. And so the really, and I talked about this briefly, the way that you distinguish demoralization from depression is demoralization is David Kassane, who came up with the term demoralization, said that the determining factor is this thing that he calls subjective incompetence. That sounds really pejorative to me, right? Telling someone you're subjectively incompetent. But all that is it means I don't have the ability to cope with this problem. And so that versus depression, which is diagnosed largely because of anhedonia, which is a fancy word that just means I can't experience pleasure in things in my life. And so that's where if a medical doctor is sitting down with someone with Parkinson's disease and considering these things, there are going to be questions that they ask about that. I mean, certainly there are scales that we can use to diagnose depression, no doubt about it. There's even a scale for demoralization. But a lot of it's going to come with the interview with patient and doctor and the questions that someone asks. And we talked a little bit about why demoralization happens. Angela brought it up. All of these things that flood you the moment of diagnosis. Intolerance of uncertainty, right? What's life going to bring? I have no idea what's going to happen now. And who am I now, right? So often we define ourselves by what we do and the people we connect with, our work. And all of a sudden, when those things change, we begin to lose identity, and who I am changes. And that can lead to a demoralization. There's very limited work on demoralization in Parkinson's disease. A couple of studies that have been done, and what they did was just look at the incidence of demoralization in people with Parkinson's. The reports that were found were around 20% of people with Parkinson's experience demoralization. I would argue hard that it's much higher than that. The challenge becomes distinguishing demoralization from depression because they overlap. Even throw in apathy, which we're going to talk about in a minute, which is another challenge that we're faced with. So here we go, apathy. Apathy is one of the biggest challenges, I think, that the medical community faces with how to treat in people with PD, right? It's very common. The reports on how much apathy is out there is wide ranging. Up to 70% is what we've seen in the literature. I think if you look at the average of a meta-analysis, you're probably looking at 40 to 50% of people with Parkinson's disease experience apathy, which really is just the loss of goal-directed behavior and a lack of motivation, right? Apathy is you want to go exercise. You're sitting on your couch and you know exercise is good for you, but you just can't get up to go. Just no motivation. Even though you know it's a good thing, there's this behavioral component that prevents you from actually engaging. And the challenge is, number one, diagnosing apathy, because it's similar to depression. The symptoms overlap with depression and with the dementia diagnosis. The other challenge is no treatments available. There are a variety. Cholinesterase inhibitors are tried periodically. Dopamine can have some positive effects on apathy. There's not anything that's been shown in the literature or even really anecdotally from the conversations I have with providers who say, this is my go-to with apathy. There's just not. It's kind of like, let's just throw the kitchen sink, try A, try B, try C, try D, see what works. And one of the other challenges is that we believe the best treatment for apathy is behavioral interventions, right? Counseling, let's say, coming to see a therapist, having some CBT therapy, and you talk about apathy. Well, think about that, right? If I prescribe to someone who has apathy that they need to go have counseling, challenge is going to be getting them to go to have counseling. So it's really difficult to do studies with people with apathy because you're going to have a lack of engagement and you're going to have patient dropout. They might go to one session and they never go back. So it's really difficult. We've done a little bit of work on apathy. I published a paper maybe 3 years ago that showed that people who have higher meaning in life have lower apathy. And meaning in life is on a couple of slides from now that we're going to talk about. Interesting finding. So if we can help someone find meaning and purpose in their life, we believe apathy can go away or be reduced. I wouldn't say go away. The other thing that we just had at the Parkinson study group back in November, I was part of a group at Virginia Commonwealth, and we were looking at retrospective data from the clinic where they treat patients there. We found this association between employment. People who are employed have lower apathy. Now, they began to look at that data and break down employment. The interesting finding about that, it doesn't have to be full-time paid employment, doesn't even have to be paid employment. What we look at it as is you're engaging in something that brings you purpose, your apathy gets better. So I think we're always cautious when we use that word employment. You know, if I'm talking to somebody who's in their mid-70s and they go, Brad, I've been retired and I'm not interested in working. You go, yeah, maybe like example would be my mom. She's getting ready to turn 79. She spends a day a week volunteering in a shelter for people who are struggling with recovery. And that brings her so much purpose in her life. She's not paid for it. She just shows up. And it's a wonderful thing to think about. And we're going to do more research on that, specifically giving recommendations. Another big one, loneliness, right? We heard about loneliness in the literature. I think everybody's been clear that loneliness is a problem forever. But we didn't talk about it or see the ramifications of it nearly as much until COVID. COVID came along and we had social isolation, we had the lockdowns, everybody's tied to their house. Loneliness goes up, depression goes up, substance use disorder goes up, divorce goes up, right? All of these negative things go up after COVID or during and after COVID because of the loneliness. And it's important to make a distinguishing definition that loneliness is really more about quality than it is about quantity. Some of you may have experienced you're in a room of 100 people. So you're not alone, you're not isolated, but you can still feel lonely. You can still feel like there's not a lack of real connection with other people. And that's how we look at loneliness versus social isolation. And it's really how I feel about the relationships that I want, the desired versus actual. I desire these quality relationships with other people that are deep, that are connecting, but I don't have them. That's when loneliness comes in. A lot of issues associated with loneliness: increased dementia, increased likelihood of developing Alzheimer's, depression, anxiety, cognitive decline, coronary heart disease, increase in stroke, right? All of these things associated with loneliness. And so we realized the Surgeon General posted a report a couple of years ago showing the significance of social isolation. The problems associated, the mortality associated with social isolation is greater than smoking 15 cigarettes a day. Wow. In fact, you could combine physical inactivity and drinking 6 drinks a day, and you still don't have the mortality risk that you have from loneliness. That's significant. And so what do we do about this? And we've talked about this in a couple of our papers, this idea of social prescribing, right? Doctors prescribe Cinemet, they prescribe physical therapy, they prescribe exercise. What about prescribing engagement in the community, right? As part of my treatment for you, I want you to, once a week, have lunch, dinner, coffee with a friend where you connect. What about joining a group like this, where you're coming together with a common shared purpose and you're engaging with each other? Exercise classes where you're with other people, not just physical therapy where it's you and the therapist, right? The value of that is critical. And I think that that's an area that, again, that we're seeing more and more discussion about in the PD world. Question?
Yeah, we got a question for you, Brad.
Yeah.
Is procrastination a part of apathy, demoralization, or something else?
Yes. Yeah. I think procrastination really is a fear-based challenge that we get into, that we're oftentimes afraid of facing this issue. So we procrastinate it and we choose not to engage. I think absolutely that someone who is apathetic is going to procrastinate because there's no motivation to begin the process. But I also think somebody who's struggling with depression can not engage in things that they want to engage in, particularly if it's something that's enjoyable, right? Because the anhedonia, the inability to experience joy, prevents someone from potentially engaging. So that's I think a lot of those issues can fit in procrastination. Throw in anxiety as another thing that's associated with procrastination. But I don't know that there's one that I would say this is the number one factor that contributes to procrastination. But I think they all contribute. But great question.
And I had a question about that. I've heard talking in the community about the inability to start something. Are they talking about apathy at that particular part? Even like this, even speech, start hesitation with speech, and is that all kind of the same mechanism in the brain that has or have they figured that out yet?
Yeah, no, I don't know the exact answer to that, Angela. My gut response to that is a speech initiation or a gait initiation in someone with PD is different from the behavioral syndrome of apathy.
Got it. Got it.
Right? Because that's more of a the speech and the gait is more of a dopamine and a brain dysfunction that's causing this issue, rather than the behavioral manifestation of lack of motivation. Now, I do think that dopamine plays a role in apathy, right? When we look at what causes these things, there's some pretty good data that looks at the role of dopamine with apathy. And so that's part of it. But it's interesting that we don't find that giving dopamine reduces apathy. And so, right, we have different receptors for dopamine. And so we've got to think about that process. What's the receptor? Which receptor is being affected, and which one are we giving the medication for? So yeah, I think they're a little bit different manifestations.
Thank you.
Yeah. So interestingly about loneliness, 2 years ago, study in JAMA that looked at people who were lonely had an increased risk of developing Parkinson's disease. Now, this is significant. 500,000 people were included in this longitudinal study, which means it looked at people over time, right? It wasn't just an analysis where we took a bunch of cases of people and we tried to go retrospectively and look at what were the associations. We looked at people over time, and that's a really interesting finding. And the challenge with that finding is there's not a great reason to why that is. I think that when loneliness can result in metabolic issues, right? So we know that there are things with our cells in our body, with the mitochondria, that can affect Parkinson's disease. There's thought that could be associated with loneliness. inflammatory response, neuroendocrine pathways can potentially be related to, or we know are related to Parkinson's, also associated with loneliness. So there's more research going to be coming about this, but that's a pretty robust finding. And it's fascinating, right? Anything that we can find in the world of Parkinson's that could be preventative, protective, is a beautiful thing. There's a cure, we've still got a ways to go. But can we find some things that are more protective and preventative? That seems to be where the bang can be. And of course, loneliness negatively affects motor and non-motor features. We saw this during COVID. We wrote a book chapter on loneliness and looked around the world at how basically every symptom got worse in every country of people who had Parkinson's disease during the COVID pandemic. So things just get worse. So here we go. Tell you all of that stuff about Parkinson's. These things are bad, right? These things are things that we struggle with. So the question becomes, what do I do about them, right? Can I change any of them? Well, these are the things that most doctors are going to talk to you about how to deal with your Parkinson's. Regular physical activity, right? We know this. Eating a healthy diet, whether that's the Mediterranean diet, the MIND diet, which largely are fruit and vegetable-based diets, nuts, olive oil, things like that. Not a ton of red meat, right? Protein, but you can get that from legumes, other healthy things. We know that those Mediterranean diet in particular, there's good literature on. MIND diet, we're seeing more. Outside of that, and even with that, we're not seeing a lot of data that just says you should be on this diet, right? I think there's some associations that say people who are on the Mediterranean diet tend to fare a little better than those who don't. But I think those are the recommendations that I think most medical providers would recommend if you ask them. The social connection piece is critical because we just talked about loneliness. So doctors are probably telling you to make sure you connect socially. How do you manage stress? Stress is critical. Stress develops cortisol in our bodies when we get stressed. The negative effects of cortisol in our body over time are dramatic. So we need to manage our stress. Stress makes symptoms worse in Parkinson's disease, right? You guys who have dealt with Parkinson's understand that. And then getting adequate sleep. So these are like the 5 pillars of things that we can do on a daily basis to help improve. That's great, Brad. But what about the other things that you just talked about, right? So I thought I would just start with those. These are the basics. I think you guys all know these. So one of the areas that I'm fascinated with is meaning in life. And I think that we can learn a lot. If you're not familiar with Viktor Frankl, he's a Holocaust survivor, psychologist. I suggest that you read him. Man's Search for Meaning is the book that he wrote. And it's all about his journey through Nazi concentration camps. And these are just some of the quotes that he says that are fascinating to me. When we're no longer able to change a situation, we're challenged to change ourselves, right? Those who have a why to live for can bear almost any how. That came from Friedrich Nietzsche, but Frankl loved it. And what that means is the why, in life is my purpose. What is that thing that I live for? When I have that, whatever I've got to go through to get to that, I can manage. And he came to that because that's what he saw in concentration camps. People who had something to look forward to when they got out fared better than those who just didn't. In some ways, suffering ceases to be suffering the moment one finds meaning. Striving to find meaning in one's life is the primary motivational force in man, right? We need meaning and purpose in our lives. When we lose it, bad things happen. So, what are those bad things, Brad? And what are the good things that you get from meaning? Ton of research on this, right? Meaning's associated with more positive emotions, better relationships, greater life satisfaction, more self-esteem and self-worth, more positive coping strategies. Oh, so if I have positive coping strategies, my demoralization gets better. Exactly. More hope, more optimism, more resilience, better health-related quality of life, greater well-being, less apathy, depression, and demoralization. Wow. So one simple thing that we can all do to improve how we feel, how we interact, how we live our lives is find meaning and purpose. That's great, Brad. How do I do that? Right? So you look at the literature on meaning and you find that there are really 4 areas in life where people tend to gravitate to find meaning. Relationships, right? Who are those people that are close to you? Your family, your friends, those really close relationships are meaningful. Leisure activities, anything that you do that is the reason that you get out of bed in the morning. Maybe it's bird watching. Maybe it's playing golf. Maybe it's fishing. Fill in the blank. Anything that gives you that, I can't wait to go do this today. There's a purpose. Spirituality, right? People who have a spiritual connection tend to report greater meaning and purpose in their life. And so if that's an area that's important to you, I would say do more of it, right? How's that going? And that's what we would ask is if I was talking to someone, I would ask, what are the areas in your life where you find meaning? How are those things going? Are you engaging with them? Are they still giving you meaning? Could you do more, right? Increase those things. And then the last one on this list is work. Across the board, work is how many people find meaning and purpose. And so you can see what happens. Think about what happens when people retire, right? You've been working for 50 years in a career and you retire, and oftentimes health goes south because that was your sole focus in life. And mortality goes up. And it's interesting that Patricia Boyle did a study several years ago looking at people who have the highest meaning in life have a 57% decrease in risk of early mortality than those who don't have good meaning, high meaning. So meaning lets you live longer. It's what the study showed in this study. But that's pretty impressive. Meaning matters. So like I said a second ago, what you do is you find this thing in your life that gives you excitement, that you just get up every day and that's what you're thinking about. Engage with that more, whatever it is. Gratitude. Gratitude is a really simple thing that we can all do more of that has wonderful health benefits. And really, it's just a worldview, noticing and appreciating the good things in life, positive things, right? It can be considered a life orientation. We've probably all known someone who just has a grateful attitude, right? I've got a friend who was 6 years ago, he was in a motorcycle accident and he's now blind and he lost a leg. And he is one of the most grateful people I know. And he just exudes positivity, even though you look at his life and you go, how can you still be grateful, right? I would argue that no matter what your situation is, no matter how dire it may look, you always have more to be grateful for than you have to grumble about. Always. And it's a matter of the cognitive shift of which one do I focus. I tell my students all the time about, it's like at home with my spouse, right? You have those couple of things that your spouse does that really irritate you, and you could focus on those, and things at home get bad because you're irritated, you're always upset. Or I can focus on the 1,000 things that my wife does that I love, that I'm grateful for. It's just a shift of focus. It's not Pollyanna. It's not saying, well, everything's great, I'm just going to focus on the positive. But there's something to that. Robert Emmons is probably the most preeminent gratitude researcher out there. And he says it's been called the most transformative force in the cosmos. That's pretty big. So There are so many positive things associated with gratitude. Learning to cultivate that is great. What does it do for you? Similar to what we just saw in Meaning in Life: improve subjective well-being, lower stress, improve sleep, less fatigue, decreased anxiety, depression. All of these things get better when people have more gratitude. So it would make sense that we want to figure out how to have more gratitude. Again, the question becomes, Brad, how do I do that? Grateful reappraisal. Looking at my situation. There's always two ways to look at every situation, right? Doesn't mean I have to be grateful that I got diagnosed with Parkinson's disease, but it might be I'm grateful that I've been able to learn some new things about me that I didn't know before I had Parkinson's. It's always fascinating how many people I've seen post Parkinson's diagnosis who have engaged in something new that they never knew they enjoyed, they never knew they were good at, but they love it. And art is one of those things, right? Those of us on social media who follow people who have PD, it's constantly seeing these art, these things that people make from art, the pictures and the drawings, and how they're grateful that now they have this new outlet they never had before. One of the easiest ways to develop gratitude is a gratitude list. And the way we do that is every night before you go to bed, write down 3 things that you're grateful for. Every night. Now, tomorrow night, don't write down the same 3 that you wrote down today. 3 new things every day, and then watch that list grow. And think about the things that we should be grateful for that we don't talk about, right? I'm grateful for I have 2 eyes, 2 ears, a mouth. I can walk, I can talk. I have 5 fingers on each hand, right? 5 toes on each foot. The things that we take for granted, include those on your gratitude list. Grateful contemplation, thinking about the things in my life that I have to be grateful for. Expressing gratitude to other people, right? Someone who does something kind for you, someone who is just a good friend, send them a note, a text, a phone call, telling them how grateful you are for them and why. Not just, I'm grateful for you. I'm grateful for you because you're always there for me. I'm grateful for you because you love me no matter what, right? Whatever it is, that increases how we feel and the gratitude that we have. And then establishing social connections is another great way to do this. All right, we're at the end, right on time, I think. So what's the takeaway from everything we just heard, right? I think there are some interesting ones. So we talked about the doctor prescribed activities, right? The exercise, getting better sleep, eating a well-balanced diet, finding coping strategies that work. Those are essential. And I would encourage, if you're not doing some of those, begin doing some of those, right? They're essential to outcomes. The other thing I always think is important is having self-compassion, giving yourself a break, right? Doctor says I need to exercise every day. I didn't exercise today. You know what? You didn't exercise today. Maybe you needed the rest. Maybe you needed a break. Why don't we just say, I'll exercise tomorrow? I'm doing the best I can. Be easy on yourself. Number 3, connect with others. Social connection is so critical in every area of our lives. Find people whom you can connect with, laugh with, cry with, do life with. It's essential. Engage in meaningful activities. If you don't have meaningful activities, find some. If you have some, engage in them more, right? The more we do that, we saw the outcomes, the better the outcomes get. And then lastly, just develop a grateful attitude, right? Become grateful for the little things in life, and watch how things begin to change. Your attitude shifts, and it's really simple, but it's something we can each do every day. And that's all I've got. It's funny I show this slide because I showed this to my students and none of them knew who Porky Pig was. They're all too young. So they're like, what is that? Oh, yeah.
That was great. Thank you, Brad.
Thank you so much, Brad.
You
Wow.
bet.
There's so many gems in there.
Yes.
We had a question come in. Well, I'll read Joe's. It just came up now. What can I do to encourage a relative and spouse, caregiver that says, I don't want to know?
That they don't want to know about Parkinson's, or what's the I don't know piece?
Hmm. I, I would guess, Joe, did you, yes,
I'm trying to,
yes.
that they don't want to know. I think the struggle with that is the question would be, why don't they want to know? Probably because there's going to be an assumption that if they learn about the truth of what's going on, they're going to end up in this state of demoralization. They're going to feel helpless. They're going to feel hopeless. They're going to know there's nothing to do. The challenge with that becomes, if you don't, let's say that I had Parkinson's and my wife didn't want to know. At some point, she's going to see that something's not right. And I would argue that knowing what the problem is easier to deal with than the questions of what could the problem be. And then I begin thinking, is it this? Is it that? Is he dying? Does he have cancer? Does he have a brain disease that's is he getting Alzheimer's, right? Whatever it is. So there's something, we can heal much better when we're able to identify the problem, because we can't do anything about a problem we can't identify. So I think that I would encourage a conversation, and that becomes a challenge. I'm just trying to fill in the blanks with that question. If an individual knows they have Parkinson's, there must have been a discussion at some point with the spouse saying, I don't want to know. But if that discussion happened, there must have been some things going on that led to that discussion happening. So it's a tough one, and I think that it really comes down to just an effective communication where we just have a heart-to-heart talk about, we're in this together. I need your support to get through this. We need each other to be able to make this happen, and talk about what are those fears that are associated with it. And let's see where we can find support. A group like this, all the information that's out there on PF or Davis Finney or whomever else, right? How can we get that information into the right hands? So might have been a vague answer, but gave it an effort.
And let me take a crack at that for a second.
Okay, go ahead.
My first semester at 17, and I was sure I had brain tumor or something wrong with my brain. I didn't tell anybody, and I went from 17 to 23. I couldn't get a diagnosis. Didn't know what I had. Finally, at 23, I got a diagnosis, and I found out that it was something I could live with. It wasn't probably wasn't be the easiest thing, but at least I knew I wasn't going to die. So, and it was like gravy. Talk about gratitude. I was grateful that I knew I knew something I could live with. So, and that was when there was no internet. So I could, and I was in the 1 percentile at 23, not knowing very little information on Parkinson's, young onset Parkinson's. So
Yeah.
so I had to go to hospitals and doctors to get all my information, and that was it was few and far between. Finally, it took me this long to catch up to all the research and all the data, and I've learned a lot over the 40 years.
Yeah.
And I learned, and I've been grateful for any day. Any day you can live with it, it's good. It's a good day. There are good days and better days.
Yeah, for sure.
So I think it's really, but it's about perspective, and maybe being able to be malleable, and it takes some fortitude, but it's livable.
Yeah. Yeah. Thanks for that, Carl. One thing I'm just going to add real quick is I meant to say this at the beginning, but anytime I deliver this talk in this area, it's always remember that everything that was just said applies to caregivers. just like it applies to the person with Parkinson's. Demoralization is the same whether you have Parkinson's or not. Depression is the same whether you have right. So caregivers can look at this stuff and say, I can do these things too, and help my life have better quality outcomes. So, but thanks for sparking that, Carl.
Well, sure. Thank you.
Ruth Ann, go ahead.
Yeah, I was just going to say the same thing that you just said, because as I listened to it as a caregiver and knowing some other caregivers and some of the examples you gave applied to how do I tell people, how do I react to people at work and all these things. It brought back, yes, this is for caregivers as well. So thank you for doing that.
Yeah, thank you.
Well, I think, Brad, you said it during the presentation. It applies to anybody living life, because all this stuff is that I think does the chronic condition focus in and make it even more important. And they don't really tell us how to do this in school. I don't think I didn't have a course that said, let's make sure that you don't get demoralized, because you're not sure how to cope with life.
Yeah, and we all do, right? I mean, all the time, demoralization happens. You get some new news, and I don't know what to do. I'm helpless in this situation. Okay. And then how do we engage with other people and have these conversations, learn a coping strategy that works, that's adaptive, right? That's a whole nother discussion, talking about coping strategies, what's adaptive and maladaptive, and rather than good or bad. But coping is an interesting topic as well.
Well, Brad, go into that. Who would be the person that you would, if you're having a hard time developing these coping strategies, who do you think is the best person to speak with? Is it the neurologist, movement disorder specialist? Is it your GP? Is it your therapist? Any recommendations on that?
Yeah, I would say therapist would be the best. I think that the movement disorder docs have some of this stuff. And again, it depends on your relationship with your movement disorder doc, right? But I think the therapist should be able to give you these. And I can send you, I've actually got a slide that I've used on other presentations that shows you a whole list of coping strategies. I'll send that to you.
That would be great.
Things like music, spirituality, meditation, right? Exercise, whatever those things are. Even alcohol, right? We have that discussion. Is alcohol adaptive or maladaptive as a coping strategy? Well, yes, is the answer to that. It's adaptive. You've got stress and you come home from a long day and you have a glass of wine with dinner and it helps with the situation. So I'll send you that list.
Yeah, that would be great. And I know you're making these slides available as well.
Yep.
We've had some people ask that question. And the other question that's come up has been, are we making this available? Absolutely. We'll do a little bit of prep to make it look pretty and then post it on our YouTube channel. And as Amy asked, I don't think she asked everybody, but you absolutely can show this to your friends, your family, your community, your support group. Maybe I'm jumping over Brad because he's the presenter, but
not at all.
Parkinson Social Networks, that we make it available and spread the word, because there's so much good stuff in here. It's incredible.
Nothing I have is proprietary.
Okay, good.
You guys can use anything that you see from me anywhere, anytime you want.
You can write that anywhere.
Yeah, exactly.
The other question we had was a long one, but I'll read it. We know now that Parkinson's is no longer just a dopamine deficiency. Serotonin, epinephrine, adrenaline play a role in our brain chemistry. The uniqueness of all of us shows that Parkinson's is a syndrome, not a disease. Anxiety and stress is one of the standards. One standard, I guess. Shouldn't we focus on stress relief more than anything?
Yeah, I undoubtedly. I think that was one of the 5 pillars that I talked about with where we begin. I think stress relief is essential, right? Because poor stress relief is going to play into anxiety, depression, apathy, demoralization, all of these things, right? So absolutely, it makes sense, and it's learning to find, and again, it's a coping strategy, right? What is it that I do that helps my stress go down? And a lot of times that's trial and error. it's learning that, is it going for a walk? Is it watching a show on TV? Is it meditating, right? Getting involved in some mindfulness, that you can find all kinds of mindfulness routines online that are great, that many people report are really helpful. But yeah, absolutely, I think stress is an essential feature of Parkinson's disease that we absolutely need to control, and need to have some more work in that area, actually.
Yeah, I just asked everybody to unmute because I wanted to make sure anybody who hadn't asked a question got an opportunity, Brad. So does
Sure.
anybody want to throw out a question that they had or comments? Hey, Amy.
Hi, Dr. McDaniels, you mentioned something about adaptive, maladaptive use of alcohol, and I wanted to say, I think that it's maladaptive actually because it's a depressant. So, like having a glass of wine when you come home from work, that example, I think it would be maladaptive. So I'm challenging you on that. What do you think?
I think it can be, but I think it's always individual specific, right? I think that I just heard a talk from Rachel Dolan from MJF, and she was talking about this, about looking at what role does alcohol play. She was talking about diet in particular, but if it seems to serve a purpose for you, someone who's highly anxious and enjoys a glass of wine at dinner, I don't think it's going to be enough to get them to a state of being depressed. Now,
Okay.
once you get to a point where that glass of wine becomes a bottle of wine, and that's what I tell my students. I go, it's adaptive until it's not, right? You begin to realize that I'm drinking and now I'm feeling worse. That's the time that we go, maybe I need to not do that. But yeah, I understand your question for sure.
Okay, thanks.
Yep.
Well, and that adaptive until it's not seems like a really good phrase, like we were talking about procrastination. Okay, well, you don't want to get do so much procrastination and that you're just avoiding everything. That's gone too far. It's maladaptive.
Yeah, and it's like I shared the example of, if you didn't exercise today, maybe that's a good thing, right? We talk about stress management. If I'm so stressed in my life, I've got so much going on, I'm putting all of this pressure on myself of these things I have to do, I must do, I ought to do, and I took a day off, I would argue that that's an adaptive strategy to help someone cope with the challenges they're dealing with. Now, when that strategy becomes, it's been 2 weeks, all of a sudden now that adaptive strategy can become maladaptive, right? So I think it's that old line of kind of everything in moderation is part of it.
Brad, is punning, where in the scheme is punning?
Yeah, I think that certainly that's an anxiety, an issue with anxiety, right? That we typically see. It's doing these repetitive behaviors over and over and over that really have no purpose. And that's an anxiety thing. And I think that it's number one, it's being able to identify that you're doing these, because it becomes like an obsessive compulsive thing that's going on in your life, right? And so it's learning to identify those. I think it's being able to find some strategies that you can engage with that begins to help reduce those and improve them. But it's a tough one. We don't see it. I don't know what the incidence is in people with Parkinson's disease. I've actually not seen any literature reported on that. I don't think it's an overwhelming number of people who experience it, but I know that it's absolutely problematic for those who do. And it's learning, are there any strategies that I can engage in that help this? If I reduce my stress, does it help? I think there's some data that looks at that being the case, and it's learning, what can I do to help with that? And again, that begins to get, Carl, a little bit out of my purview. But so I wanted just to preface that with that.
Is that mental, or do you think it's mental or physical?
Mental. Yeah, I believe it's mental. For sure.
Anybody else with comments or questions? We have about 10 minutes left to go, and then we want to be I just forgot the word. We care about
Mindful.
your time.
Yeah.
What'd you say, Nancy?
Cognizant.
Thank you.
You
I'm
I have a
flunking the
question.
mental stuff.
have time for a question?
Yeah,
Another?
Jim, go
Absolutely,
ahead.
Jim.
I'm kind of new, so maybe this is an age-old question, but he was talking about a large study that he did, and I haven't heard a common denominator that anyone's come up with Parkinson's in terms of being around environment, chemicals, or any cause. With all the different aspects of it, I've never heard yet like a common denominator or common thread that everyone has,
Yeah.
if that makes sense.
It does. It does. And that's a good question. The struggle with that is there's not necessarily a common thread for everyone, right? We see a certain percentage of people with Parkinson's disease who have a genetic defect that causes their Parkinson's. We typically see it even more in the young onset community with the genetic problems than we do in the traditional older onset. Environmental is clearly a problem with Parkinson's. Ray Dorsey has got another book coming out where they spend more and more time talking about these environmental toxins, the things that these toxins that seep into the ground and get into the well water
have
that
some
people
more
are drinking.
updates to
And that becomes problematic. So I think environmental is really the one that I don't know that we as a field have spent enough time focusing on, because it's the one that's modifiable. And that's been Ray Dorsey's point all along. He's like, why aren't we stopping these things? And he says, I believe that we could prevent Parkinson's from happening in a large number of people if we dealt with these environmental factors that are modifiable. But as far as each individual, I think it's challenging to find what the cause for you was. And it's a really broad question that I don't think we have a great answer to. Angela, I see, just posted Ending Parkinson's by Ray Dorsey. And like I said, there's another one coming.
Yeah, Amy did that. She sent it to me directly,
Okay.
and I was like, oh, wait a minute, put it back out there.
Yeah. I just heard Ray talk at the Parkinson study group back in November, and he gave a keynote, and he's very passionate about this topic. It's kind of his thing he wants to talk about. And I think it makes sense that if we know these environmental things are causing Parkinson's, why don't we get rid of them? And the challenge becomes, how do we get our legislators involved in that, where we could begin to have policies that say TCE is not allowed, right? And all of these other Roundup and things like that, that there are some associations with Parkinson's disease. Why are we still allowed to use them? And so, and aging is associated with Parkinson's disease, right? As we age, we know there's an increased risk of Parkinson's disease. And but I think environmental's top of the list, and genetics.
I worked on a lot of materials in construction, and I always felt like aluminum, cutting it and sanding it and painting it just gave me a bad feeling. I didn't have anything to base it on, but it was almost like I was allergic to it or something. But anyway.
And
yeah.
We'll send you we'll make sure in our follow-up to this, when we send out Brad the video, the recording, we'll make sure there's a link to the book.
Thank you. Okay.
Sure.
Good suggestion, David.
Great question.
Yeah. Anybody else?
David talks about a good suggestion to join PD Avengers. I guess that's. I think we also like Christine's book. We want to put Angela, but the book of Angela.
Yeah, we can add that too, Carl, and hopefully we'll have her come. There's so many books, yeah. But yeah, absolutely.
Yeah.
We'll put that one too. Any last comments?
Just a big thank you for an excellent presentation.
Yes,
Well,
thank you.
Thank you.
Thank you.
Yeah, absolutely. Brad, thank you so much for your time and your service to the community, and continuing to give us great resources and information so that we can, everyone, both people with Parkinson's and care partners, live well with Parkinson's. So it's really appreciated.
And your
Well,
expertise.
well, thank you. Well, thank you, Angela and Carl, and the rest of you all for the invite today. This is what I love to do. I usually spend my days in my office writing and other things, but anytime I can connect with the community is really where I find my meaning and my purpose. And so this is fun for me. So I'm happy to be
We'll
here.
consider that an open invitation that you'll come
Absolutely.
back.
Absolutely. We can do it again and talk about coping or resilience or whatever else. It's an exciting topic.